The MedSearch app is a health information directory that allows users who are in search of specific medications or health services such as hospitals, clinics, pharmacies, or even veterinary services to quickly and easily access what they're looking for. It's available on Google Play Store and you can find it on Apple App Store.
We welcome you to our platform.
I'd like to assume you're introducing me right now because we're having a technical difficulty here. I can barely get you.
All right, you can introduce yourself.
Yeah, my name is Clement Phiri. I'm a registrar in obstetrics and gynecology at Ndola Teaching Hospital here in Ndola. Okay. Yeah, and just a few days ago, I received a call from my friend here, Zanga, from MedSearch Zambia, sharing with me if we could, share one or two things concerning complications that occur in pregnancy. We looked at quite a number of issues, but more specifically, we felt let's maybe focus on hypertension.
True.
And share one or two things with our viewers. True. And listeners this evening.
Yeah. Dr. Phiri, so one of the statistics that we have, I'll get an example. In America, they say 1 in every 12 to 17 pregnancies, majority of the women who experience hypertension during their pregnancy. And when you look at it at the world statistic, we see that 3 out of 7 women who experience hypertension during their pregnancy. And we've seen that this is one major problem that majority of the women go through. How serious is it?
Thank you, Zanga. Yeah, hypertensive disorders in pregnancy, there are quite a number. Hopefully, as we go on, we may try and break them down and define one or two of those. They're quite common globally, regionally, and here in Zambia, they are quite common. From 1990 to 2019, there's been a global increase from about 16 million to 18 million people having some form of hypertensive disorder in pregnancy. So there's been a global increase. More specifically, you mentioned the USA. We're talking about a 2 to 6% prevalence rate of hypertensive disorders in pregnancy. Of hypertension in pregnancy. The current statistics here in Zambia, I'm not privy to that, but these are conditions that we're treating on a daily basis. When women come to us, I'd like to believe almost on a daily basis, you're attending to a woman with some form of hypertensive disorder in pregnancy.
Bring it back home. How serious is it? I know you've talked about it. I hope you're getting me. I know you've talked about it. How serious is it here in Zambia? Yeah. How serious is it here in Zambia? Well, when you talk about hypertension in pregnant women.
So it's quite a serious condition that requires and deserves special concern. Generally, hypertension is a common disease process here in Zambia and globally. But more specifically in pregnancy, it's a condition that we're seeing on a daily basis, and some of the implications that it has are quite drastic, both to the baby and to the mother.
All right.
So it's one condition we try to be as aggressive as we can to try and manage it, looking at the implication it has.
Okay, let me bring on board Dr. Moses Mata. He's my colleague.
Okay.
He has joined us tonight. Mata, welcome. Oh, he's still mute. Yeah. Maybe to kickstart the ball rolling, I know many people who are watching might not be medical personnel. What is hypertension? Dr. Phiri, we might be talking about something you and I are preview to know what hypertension is, but many
Exactly.
people, many people might be strange. This might be Greek to them. What is hypertension?
So when we talk about hypertension, it's something people commonly refer to as BP.
BP, yeah.
Yeah. In Bemba or in Nyanja, they'll say abaja balina BP. That person has BP. But if we were to get more technical, we'd say we all have a BP. But this BP has a range in which we say this is normal BP. Yeah. However, if this BP goes within the the average limit, then it begins to give us an issue. Either it's going up or it's going down, it's an issue. So more specifically in the discussion we're having tonight, we're talking about elevated BPs, BPs that go up, and the effect that those BPs will have on the well-being of the mother and the baby she's carrying. So to try and define what hypertension is, so if I could simplify this further, I would say each human being has blood that's running through their veins, and that blood moves at a speed, that is influenced by a number of factors, mainly because of the audience that we have. The heart pumps, and it's pushing blood to the entire body, to different parts of the body. That blood is carrying with it nutrients, oxygen, and all the important requirements that the body needs to function, and also taking away waste material back to where it's going to be disposed of. So that's the role that blood is doing this. But blood does this optimally well at a certain speed, if I can put it that way.
All right, yeah.
So this is the speed that we're talking about, and we want it to be within a stipulated range. If it goes beyond this range, it begins to cause problems.
Okay.
It begins to cause damage to different organs in the body. It can affect the brain, it can affect the heart, it can affect the liver, it can affect the kidneys, it can affect the limbs, it can affect so many different parts of the body. So we endeavor to try and maintain it within what is seen to be a normal range. So these effects it has, in part I'm mentioning the complications it will have on the mother. This effect it has will also affect the baby.
Yeah, we're following. Really good. We're following.
Yeah. So to define, we have different types of high BPs in pregnant.
Okay.
So we can have mothers who've had high BPs even before they fell pregnant, and they fall pregnant and they still have elevated BPs, and hopefully this mother is on medication, and these BPs, there's an attempt to control these BPs and keep them within range. So this is a type of hypertension we call chronic hypertension. Then when the mother falls pregnant, she can develop hypertension that is as a result of this pregnancy that she's carrying. Certain things go on as the baby is developing. The mother develops what is called a placenta, which is an interface that connects the baby to the mother. So this interface, a number of things take place in the placenta, and considering its development, if things don't go well in its development, it may cause this mother to begin to develop high BPs. And our focus with this type of hypertension is when this mother is beyond 20 weeks gestation. This pregnancy is over 20 weeks. 20 weeks would be about 4 months plus. So if these BPs begin to go up after 4 months, we are concerned for the mother. We know something went wrong during the development of the placenta. And depending on whether we see evidence of damage occurring to the kidneys, these high BPs may be termed as Pre-Eclampsia. That's if when we do, we measure protein in the mother's urine, we find there's evidence of protein. And of course, there are other defining factors that I won't go into so much. And for the purposes of our audience understanding better, if we discover that there is protein in the mother's urine, we define these elevated BPs beyond a certain limit as preeclampsia. However, if there's no protein in urine and these BPs begin to go up after the 20th week of gestation, it's equally a form of hypertension, but we describe this as pregnancy-induced hypertension. These two BPs that I'm talking about that occur after 20 weeks of gestation and can occur at any time after 20 weeks, even after the mother has already delivered. You can find she develops. You can find that this mother develops high BPs post-delivery, up to 6 weeks post-delivery. Some will say up to 12 weeks, but up to 6 weeks, the mother's already delivered, you find BPs begin to go up. You can still define these BPs as BPs coming up as a result of this mother's pregnancy. Then also there are certain other types of BPs where before 20 weeks gestation, the mother suddenly starts having very extremely high BPs, which may be caused by a certain type of pregnancy we call a molar pregnancy. Yeah. There are plenty other causes of high BPs in a mother that may be resulting from other disease processes, but for the purposes of this discussion, we can stick to the ones I've mentioned so far. And in addition, I forgot one more.
Okay.
The mother may have chronic hypertension, which we said these are BPs that the mother has been having even before she fell pregnant. And now she's pregnant and she goes beyond the gestation of 20 weeks. And then her BPs were initially controlled and all of a sudden they start going up again. So it's like the hypertension is always had, plus the setting in of hypertension as a result of a pregnancy, being like a compounding factor. We term this as either preeclampsia on chronic hypertension, or could be pregnancy-induced hypertension, chronic hypertension.
Okay. Maybe if you, I don't know whether Matak will come in. One of the things that majority of the women will come, and I think most of the time we look at first-time mothers who come to the hospital, and this person has never had BP before. Then after 20 weeks of pregnancy, we start seeing the readings start going up. Are there any predisposing factors of a woman having hypertension in pregnancy? What could they be?
Thank you. That's a very important question. So there are quite a number, of course, of factors that will predispose a woman to developing high BPs as she's pregnant. And we try and address these. So there's a category of mothers we will call high-risk mothers for developing elevated BPs whilst they're pregnant. Yeah. So I'll give a few examples. A mother who had high BPs in a previous pregnancy is a high-risk mother for developing high BPs in this current pregnancy. A mother who last delivered over 10 years ago with a long intergestational period is likely to develop high BPs. Extremes of age, a very young mother, and this is her first pregnancy, is likely to have elevated BPs while she's pregnant. Older mothers, over 35, over 40 years old, and then they fall pregnant, they are likely to develop elevated BPs whilst they're pregnant. Mothers who have diabetes, mothers who may have a renal condition, are likely to develop elevated BPs whilst they are pregnant with this current one. Mothers who are carrying twin pregnancies, a twin pregnancy, are also likely to develop elevated BPs in this current pregnancy. that they have. So as you can see, there are quite a number of factors that we look at. A mother who's changed partners and in her last pregnancy, the person who fathered that child is not the current one for this pregnancy that she has, also at risk.
This is interesting.
Also
This is interesting.
Developing high BP, yeah, in this current pregnancy. So as you can see, we have quite a number of risk factors. And with this in mind, there will be a few special things that we'll have to do for these mothers. With once we've captured this information in history, to say this is the kind of mother that we currently have. So there are a few things we'll have to do for them to try as much as possible to prevent. And if these pregnancy, these elevated BPs develop, manage these BPs as they come.
I don't know. I'll try to bring in Matai. I don't know if you've got anything to comment.
Yeah. Hi, Clement. Again, Dr. Phiri. Hi. Great to have you, and thanks for reminding me about my obs and gyne. I haven't practiced obs and gyne in a while. But
thanks for having
I'm just
me.
trying to think. Yeah, I'm just trying to think. So I'm thinking about, I'm a young lady, or I'm a woman of any age, and I'm thinking about having a child, and I'm listening to this conversation, and I'm kind of getting scared to say, okay, I have so many risk factors. Maybe I'm 35. Maybe I shouldn't get pregnant.
Yeah.
So how? Maybe walk us through, like, what is from the medical sector? What do we do to make sure that our women, our wives, our daughters, our sisters, when they do get pregnant, that if they do have hypertension, what do we do about it?
Okay.
She's come for her first antenatal visit, and we noticed that her BPs are high. What comes next for a woman in that situation?
Okay. So to begin with, in responding to your question, what is key is antenatal care that you've mentioned. So we really urge our mothers to book early enough for the antenatal as soon as they discover that they're pregnant, or if they're planning to conceive, they begin to seek antenatal care, because it is through antenatal care that most of these risk factors will be elicited and established, and will guide us in knowing that we are dealing with a high risk mother for developing high BPs in pregnancy. So the antenatal care is quite key and vital. However, should this mother begin to attend antenatal and we discover that she has risks for developing high BPs during pregnancy, there are a few things or a few drugs that we will begin to administer to this mother to prevent the development of developing high BPs during pregnancy. However, maybe I should give a few examples. So for such a mother, we give, I don't know whether I should wait for some of these questions to be prompted, or I should go ahead and preempt.
No, it's okay.
However, so we give some of our mothers. Okay, go ahead. Okay, thank you. So we cover our mothers on baby aspirin, low dose aspirin. That's 75 milligrams aspirin. We cover them on calcium. We give them some calcium. This should help before they develop these high BPs, in trying to curb the development of the high BPs. However, should they develop these high BPs, of course, we have a list of recommended antihypertensives which are safe for the mother and the baby during pregnancy that we'll give. A mother can be covered on nifedipine. Maybe most viewers will know it as the brown tablet. This is your
brown.
Then we also use methyl dopa, kajaka white, but can also be brown.
Yeah.
We use methyl dopa. We use what we call labetalol. though it's become quite common now, but before then we never used to commonly have it in our hospitals, but it's available now and we're using it. And so all these drugs will be employed depending on the level of elevation of these BPs. And we have guidelines that guide us which one we start with and which ones we introduce with time in trying to arrest these elevated BPs.
Great. Dr. Phiri.
Okay. No matter, you can go ahead.
You touched on, and yeah. So Dr. Phiri, you touched on the medication and used, I think, an important word there, safe for us to use in pregnancy. I just want you to talk a bit more about that, because we know that sometimes people will give advice who are non-medical people as well to say, you have high blood pressure, take this one, take this one. And our mothers may not even come to the hospital as often as they should be, because they're being given medication. Maybe a spouse is also hypertensive, so they start taking their spouse's medication, or they just go to a nearby shop where the people there are not really following guidelines and they're just giving medication. I just want you to talk a bit about the importance of making sure that any medication, even for hypertension, that is being taken in pregnancy is one that has been prescribed, and the safety reasons for that.
Thank you so much. That's a very important question that you're asking there. And I hope our viewers take this seriously. It's common practice, like you've said, maybe spouse is also hypertensive and is taking some antihypertensives and decides to share with the wife, or neighbor whispers to the friend to say, when I was pregnant, this is what I was using, or I'm hypertensive, this is what I'm using. And we do understand that an individual is likely to listen to somebody that is close to them than a complete stranger. Yeah. So, however, we are talking about a mother that is, carrying a baby that I would like to believe is important to her. So the medication that the mother takes has to be something that has been tried and tested and has been found not to cause any, drastic effects to the mother and the baby. So there are a number of restrictions with pregnancy. Pregnancy is a special case, so we don't encourage people to self-medicate or just walk into, I would like to believe if they walked into a pharmacy or a drugstore, they'll find qualified people there that will advise accordingly on what the right thing to do is. So we encourage that mothers come to hospitals and seek antenatal care. They'll find doctors to see them, they'll find midwives to see them, they find people that are qualified to attend to them and guide them accordingly. Because if you self-medicate or you take medicines that are not recommended in pregnancy, it may have devastating effect on the baby that the mother is carrying. The mother herself may be able to bear the effects of the drug, but it may affect the baby, especially in the first 3 months of the pregnancy, when the baby is just, developing key organs that will be essential for life. So if a mother decides to self-medicate, these are some of the concerns that we have, and we encourage that every mother seek professional help.
Maybe I'll try to again bring you back in. Is this why would you encourage mothers now to be attending antenatal? Because we've seen majority of the mothers, both peri-urban and rural areas, even now urban areas, where mothers want to not attend antenatal and only want to come to the hospital on the day of delivery when they feel. Do you think this is very important for mothers now to be attending antenatal, because we're now able to follow their BP profile, so we're able now to direct them, tell them what to do and what not to do? I'll try to bring you on that.
The point you're raising, Zanga, is a very important point. I think the the plan, or rather the mandate of Ministry of Health, is to make sure that all our mothers attend antenatal care in health facility, and so that they receive quality care. So if the emphasis, it cannot be overemphasized that our mothers come and seek antenatal care from hospitals, because whatever medical condition or obstetric condition that may arise will be picked up much earlier and much quicker. But often at times, like you've mentioned, where you have a mother comes to deliver with an antenatal card with probably 1 or 2 antenatal visits, and then upon admission is when you realize she's been having elevated BPs for some time. You determine a gestation age. For example, she's 37 weeks, she's 9 months, and then you try and assess the baby. The baby looks way smaller than a 9-month-old baby should be, because these are some of the effects that the elevated BPs will have on a growing baby. They'll suppress the growth of the baby. Baby won't grow up as baby should. So we encourage that mothers attend antenatal care in established facilities.
Jumping now to, I'm trying to look at the time so we don't keep you for long. Jumping now to treatment. So here comes the mother, and her BP profile for, let's say, 5 to 7 visits have not been controlled. You've talked about some of the medications. What are other treatment options that are available for mothers who've got elevated blood pressure?
Okay. So in responding to your question, if I could pick one of the hypertensive disorders in pregnancy that I endeavored earlier to try and define, is preeclampsia. Yeah. So these are elevated BPs that are developing in a mother after 20 weeks gestation. And if you remember, in trying to describe what type of hypertension this is, I touched on the placenta to say in its development, if things don't go well, a mother can eventually develop preeclampsia. So this is a multi-systemic disease and is affecting different organs. In its in treatment, of course, we'll give different drugs but however, the definitive ultimate treatment for these BPs to go away is delivery of the baby. So the baby has to be delivered. So now you can imagine a mother that comes to you, has been having elevated BPs, and comes to you, say she's at 4 or 5 months, or she's at 6 months. And the behavior of BP oftentimes is it will be asymptomatic. She'll bear no symptoms. Then she'll come through, and then you do an assessment that tells you this mother has been having very high BPs. You draw some bloods and do some investigations, show you these BPs are affecting her kidneys. These BPs are affecting her liver. And the ultimate decision made now is we have to deliver this baby. And you can imagine this is maybe a mother that has tried. She's had 2 miscarriages. This is a pregnancy that she's seen or carried to more than the previous ones. It's a precious baby to her. And coming to the hospital only to be faced by information that is suggesting early delivery of this baby is a huge challenge that we face. So you tell this mother, we have to deliver this baby. This won't be the easiest thing for her to agree to. She will call on family. She will call on, she wants to talk to somebody that is close and help her make this decision. And oftentimes mothers will even, opt out and say, maybe let's seek a second opinion at a different facility. And this is a mother with very high BPs that you are sure this is not a person you can allow to go home. This is somebody you have to keep within, within the hospital. But the information you are giving her, for you that understands, you know exactly what needs to be done. But also on our side, it may not be the easiest decision for her to make. There'll be a number of factors that will influence the decision that she makes. So she won't be easily agreeable. However, the some of the things that may arise from this is if the BPs are so high, the placenta can mount off the uterus, and eventually she can lose the baby. You can have what is called an abruptio placenta.
Yeah.
Then she can lose the baby. Not only these BPs can injure her kidneys, such that whatever outcome with regards to the baby, you find here's a mother now that has to attend dialysis for the rest of her life, which really compromises her quality of life.
True.
So this is something that can be prevented through antenatal care. If a mother begins to attend antenatal care soon enough, you can pick up some of these things and address them accordingly. Furthermore, this mother can eventually convulse, have a fit, what we call, now this preeclampsia would have converted to what is called eclampsia. So a mother can have a fit, and you know, when somebody is having a fit, there's insult to the brain. So there's no guarantee how the mother will come out of this fit. You know, we hope and pray for the better, but at times the outcome can be a poor one, and it's quite sad, and we see this quite often. We've even got, I know of a mother who went through the same. She's running some sort of a support group. So she comes through. If you're having mothers who you're facing challenges arriving at such decisions, so we engage her. She comes through and talks to our mothers, and hopefully they can listen to somebody who's experienced what they're going through.
Dr. Phiri, I'll bring in Dr. Mata, then I'll go to some of the questions, and I'm encouraging those who are watching and you've got questions, please do ask in the comment section. Today, Dr. Phiri is on the hot seat, so we'll not let him go until he answers your question. Mata.
Yeah.
Yeah, Dr. Phiri, thanks for all of that very useful information, and also just walking us through the complications of preeclampsia and eclampsia. I think one of the things, the big things we're trying to do now is to reduce maternal deaths. And I know that preeclampsia and eclampsia is a big cause of maternal mortality. I wanted you to talk, just to take you back a little bit, because you were talking about how a lot of the time hypertension can be asymptomatic. But with a lot of hypertensive patients, not all hypertensive patients, but there's this belief that I know my BP. I know what my body feels like when my BP is high. And then a lot of times you find that by the time this person is coming to the hospital, they're coming in with, and this is away from mothers, but I'm sure it's pretty much the same. By the time they're coming to you, their BPs have been in crazy ranges for quite some time. So what's your experience with this belief that I know what my BP feels like? I know what my BP, when my BP is high.
Thank you so much for that question. What you're saying is, like, you're speaking my mind, and I hopefully mind of some of the people that are online with us right now. It's a typical finding of people saying, I know my BP, I can tell when it's high, I can feel it. You know, people will tell you that. But what I've come to realize is most people are in denial, and not only them. I mean, I've had moments where I have malaria and I have to take pills for 3 days. It's not the easiest thing. So I try to understand people who say that, but also give them time, but then weigh in and give them professional advice in the best way possible. You know, I've got relatives who say, who I know are hypertensive, but they struggle to take medication, and they'll tell you, I haven't checked my BP, I haven't taken my BP medication for the past week because I feel fine, you know. And at times people put it up to prayer. They say, no, God forbid I can have such a situation. However, with that said, even with prayer, it requires you to take some action. True. And if the recommendation is that you take some medicines, that's exactly what you should do. Yeah, because we believe God speaks through people, you know. That's why he's given us all this information, all this knowledge for us to be able to help each other. So we encounter mothers who say, you can tell, I mean, because when you interact with so many of them, you can tell that there's poor compliance here. This mother is not taking her medication. And oftentimes we encourage couple counseling, hoping the spouse is there if they can make it. And you talk to a partner who can be there to remind them of the importance of why we are asking them to do certain things. And to my fellow clinicians, this is the emphasis. Talk to your patients, to your clients. Explain to them why you're asking them to do certain things that you're asking them to do. Don't leave it up to them to go and Google. They'll find so many things that will scare them. So explain to them clearly why you're asking them to take these advantages. Yes, run them through, help them understand. With understanding, you'll find you change the perspective, the perception they came with, and they'll be able to see things different. So yeah, we do want our mothers if they're found to be having high BPs, they should understand the complications of the high BPs that they're having. Share with them the information, not to scare them, but to let them know that this is what may happen if they don't. You know, we've had mothers decide to go home because they couldn't make the decisions, some of the decisions we are asking them to make. And they still come back after some time and deliver a healthy baby. It's not up to us to say, who are next? No, we still receive them the same way. So we encounter these mothers, and our emphasis still is for them to book early for antenatal and attend antenatal care at a recommended facility.
Dr. Phiri, some of the questions I think Dr. Mataz asked one already, and that was the same. How can I know that I've got BP? And you've mentioned that I think you've stressed an important point, which is attend antenatal. Do not attend and do not home attend antenatal. Go to the health facility. Let the clinicians see you. Let them document. There are some things that your eyes will not be able to tell, but if you go to the hospital, clinicians will be able to encourage you. The other question that I've got, it's a concern by I think this should be a married man. Traditional medication. My wife goes for traditional medication during her pregnancy. I don't know if you've got I think majority of women in peri-urban and rural areas, it's like traditional versus conventional medication. Majority always go for traditional medication. I don't know if you've got a comment on that. And then another one, so that you can answer them together. The other one is, she has delivered. She was found with BP during her pregnancy. Then she delivered. Her BPs haven't gone down. Are her BPs ever going to go down? Those are the two questions that I've gotten from the comments.
Okay, thank you. And also, before I respond to these questions, I think I didn't fully exhaust responding to Dr. Mataz's question. I mentioned earlier to say most often BPs will be asymptomatic. And how can you tell? The only way you tell is putting a cuff on a patient's hand or where it best fits, and then it gives us a reading, you know. And we do that reading. It tells us these are the readings. If they are high, our guide is BPs over the top reading over 140, whilst the bottom reading is over 90. That's an elevated BP. So a BP machine will tell us, and we have to do these readings 4 hours apart. So we take one reading now, then 4 hours later, we repeat the readings. But at times, there are once-off readings. You measure somebody's BP, you find the upper part is over 160, the bottom one is over 110. We immediately begin to address the issue, begin to manage the issue. This is for people who come in and they don't have any specific signs to show that they have elevated BPs. However, there are people that will come in with elevated BPs that is presenting with signs. So these signs, I'll mention a few, or so rather symptoms. I'll mention a few symptoms that these may be. So somebody can come in complaining of a headache. Somebody can come in saying they're feeling dizzy. Somebody can come in saying their vision is a bit disturbed, it's blurred. Somebody can come in bleeding from the nose. Somebody can come in vomiting. Somebody can come in complaining of pain in the chest or pain in the upper abdomen. So all these are symptoms that will tell us, coupled with a reading and a urinalysis to check how the urine is. These are some of the things that will guide us to be able to tell exactly what type of elevated BPs we're dealing with. And then coming to the questions you just asked, you talking about the use of herbal medicines. I'm a person who visits the village a lot, and I've got a grandmother who uses that, and not only a grandmother, a number of people in the village who use herbal remedies that work. I can't, I can't come here and completely discredit some of these things. We've used these things in time immemorial, and if they work, they do work. However, the issue is, consistency in the use of some of these things, especially with regards to the pregnancy that we're talking about. We have mothers, there are traditions that are being practiced. You find the mother is close to term. That mother is already being given some herbal medicines that is believed to help soften the pelvis so that she can have an easy delivery. Yeah. And some of these medications that they will give what we call uterotonic medications that begin to contract the uterus in an attempt to evacuate the baby, And what may be lacking in this information is fully telling whether this woman is close enough to labor or not, or whether she's gone into labor or not, or at what stage of labor she is before you administer some of these things. Because we have conventional medicines that do the same. But this is coupled with knowledge, knowing exactly when we use some of these medicines, we're able to tell this woman has now gone into labor. At what stage of labor is she? At what stage do we begin to administer some of these drugs to help expedite the process of labor? But we get oftentimes a mother, a young woman, 18 years old, and she's got a grandmother who's acquired this information passed on to her by somebody else as well, but there's no consistency in evaluating this information and how it's being used. So you find this woman comes to you and she's having these super strong contractions. When you assess her cervix, her birth canal, you find she's remote from delivery. But however, these things have already been administered and they carry risks, This woman's uterus can rupture. It can tear on some part, and then of course you lose the baby in such a circumstance, and it may complicate the mother as well. She may bleed so much by the time they reach the health facility, it may be too late. We encounter such mothers a lot. It's something we have to deal with. So from my side, it's something we do not encourage. It's being done out there, but we do not encourage. The emphasis is when a woman is pregnant, the place she should go, because ultimately, even when they experience these complications, that woman will still end up at the hospital.
True.
That recommendation will probably come from the same grandmother or aunt or somebody who administered the same herb. So our emphasis here is healthcare should be sought at a health facility. Yeah.
The other one was with
the second question.
Yeah.
Yeah. So the second question is coming from a mother who had high BPs while she was pregnant. Then post-delivery, she's still experiencing high BPs. Mm-hmm. Yeah. So that is it happens. It's expected. Oftentimes, the moment you deliver, if we're dealing with preeclampsia or we're dealing with hypertension that is as a result of the pregnancy, the moment you deliver the baby and you deliver the placenta, you find these BPs normalize. But at times that may not be the case. And even in my definition, remember I mentioned at times these high BPs may develop post-delivery. Mother's already delivered and then she begins to experience high BPs. So in such an instance, we still manage her accordingly. But the beauty now that she's delivered is that all the antihypertensives that we have at our disposal, we can use any now because she's no longer carrying the baby. So we try and keep them in the hospital a little longer than a mother with an uncomplicated pregnancy, so that we monitor them. Some of the complications of high BPs is that a mother can begin to accumulate fluid in her chest and compromise her breathing. So we've had instances where a mother leaves hospital earlier without medication, and then they find themselves home. Then a week later, they come back with complications, difficulties in breathing. Then we know her post-delivery management was not adequate. So most mothers, we endeavor to keep them in the hospital a while longer to make sure that they receive the care that they deserve. They go home on antihypertensives, and even as they do so, we give them a short review date so that they come back and we reassess them and see whether they are good to go home for a much longer period.
I'll bring in Dr. Mata, but there are just two more questions, and due to time, we don't want to keep you for more than 45 minutes, though we've passed that. The other one, I think this lady is more of, with me, it's more of heart failure, because she's saying, I get tired easily, can't walk, and she's pregnant. I get tired easily, can't walk much, I can't do any house chores, I can't stand up, I usually have heart palpitations. If such a lady had to come to you, what would be your advice? And then, Dr. Phiri, you had started an atomic bomb. There's a question here, why is change of partner a predisposing factor for pregnancy, hypertension in pregnancy? Those are my last two questions. You'll be able to respond.
Like you mentioned, looking at the time factor, I will respond to some of them. Some are encouraged that if our viewers could visit some of our facilities, we'll be able to exhaust some of the questions that they have.
Yeah.
Yeah. So the first question you've asked is, what was the question again?
She usually gets tired. She's pregnant. Usually gets tired. Can't walk. She usually gets heart palpitations.
Okay, so for our mother there, in part, some of the things that you've mentioned that she's experiencing maybe as a result of the pregnancy itself, but from the way she's describing it, I don't know whether this is her first pregnancy or she's had other pregnancies before, and this pregnancy feels different than the ones she's had before. So, however, if she's, the best would be, we would need to fully, evaluate and assess this mother, take a good history, and then establish exactly what is going on, and run a few investigations, and they should be able to guide us in telling exactly what we're dealing with.
And then the last one
then
was...
secondly, there's a question. This question does not go down morality, no. However, studies have shown that when a mother changes a partner, so this is a question that we ask when we receive our mothers in our delivery rooms, or they are coming to antenatal. We try and establish if we see a need to ask such a question. She comes to us and we're seeing elevated BPs, and we run a thorough history and ask more questions. And then this is one of the questions that usually come up. Is the father of this current pregnancy the same as the previous one? So studies have shown that if there's been a change of partner, you'll find this mother is at risk of developing elevated BPs.
I'll bring in Dr. Mata before we close. Doc.
Just in 2 or 3 words, Dr. Phiri. In Zambia, we believe that if I am hypertensive, I just need to drink 6 liters of water every day and the BP will be controlled. What do you say about that? from the pregnancy perspective.
Okay. Drinking water, I mean, is something we encourage everybody to do. We encourage everybody to be well hydrated, pregnant or not, male or female, is something important to do. However, if your BPs are elevated, in trying to manage elevated BPs, there are measures that we employ. Some of them are medical, some of them are not. So some of them border on diet and exercise. So one can manage their BPs just on dietary advice, certain changes in their diet, and exercise. There are recommendations for exercise. Certain BPs can be managed as such, but not all BPs can be managed in that way. At some point, you'll find that medical management will have to be employed. So drinking water, everybody should be drinking water.
All right. To our viewers, thank you very much for joining us. We had Dr. Phiri. We usually ask our guests one question. Dr. Phiri, do you have the MedSearch Zambia app on your phone?
Okay, this is a this is an ambush question.
He's going to download it right now.
Yeah, I know. From our discussion today, hypertension in pregnancy.
Hello?
Mata, I think you can take over.
Yeah, I think we may have lost Zanga there for a second. So in our discussion today, we're talking about hypertension and particularly hypertension in pregnancy. And Dr. Phiri has walked us through the different types and how they present, when they present, and importantly, the complications, why it's important to manage hypertension in pregnancy. So our encouragement to all women who are thinking about pregnant, who are pregnant, is to make sure that you visit your nearest health facility, and you can download the MedSearch Zambia app to help you find facilities close to where you are that are able to offer antenatal services that you'll be able to visit to have your blood pressures checked on a regular basis, and so that you can be seen by a licensed healthcare provider. We'd like to thank Dr. Phiri very much for appearing on our show. And to everyone, as always, download the MedSearch Zambia app free on your mobile devices, both Android and iOS, so that you can find health facilities such as antenatal services where you can go to be seen and have your blood pressures checked and have your pregnancy taken care of all the way from conception until delivery. This has been MedSearch on Friday. We are MedSearch Zambia, where healthcare simplified. Thank you very much, Dr. Phiri.
Thank you so much.
Everyone, until next time.
MedSearch Zambia app, healthcare simplified.